I try not to pigeonhole theory about the biology of depression. I assume any cognitive change in the brain has a neurobiological underpinning. I also think that you have this kind of feed forward and feedback process where
it's a vicious cycle.
Exactly. One of the kind of really important ideas in this era for people to understand is that their depression and their overall health are very closely related. So if they have an episode of depression and they don't treat it, that will not only affect their attitude and approach to the world, but it will set them up for other medical problems down the line. One of the things that's really kind of exciting about drugs like ketamine is they're not only doing a little bit better job in getting some of these folks better more rapidly and more effectively than standard antidepressants, but they've been protective against relapse.
Hey everyone, I'm Larry Weeks. Welcome to another episode of the Bounce Podcast. On this podcast, we're going to talk about brain chemistry, specifically what happens in our brains when we are traumatized, severely depressed, or anxious. And for those who are stuck in that state, what are the latest clinical treatments using medication that can help someone get unstuck from that state? So consider this a bit of equal time. I've had a ton of discussions with psychologists, physicians, and philosophers about managing thoughts, managing our thinking when it comes to setbacks, dealing with challenges, so on and so forth. But I would be remiss to leave out the physiological side of emotional resilience, or lack of same. There are upstream and downstream biochemical events that either result from or cause depression. And I should not ignore that, and we should discuss that. Hence the topic of the podcast. And my guest on this episode is the distinguished Dr. John Krystal. The superlatives here are many, so bear with me because it's a mouthful. Dr. Krystal is the professor of psychiatry and neuroscience and psychology, chair of the Department of Psychiatry at Yale University, and chief of psychiatry behavioral health at Yale-New Hospital. Dr. Krystal is also a leading expert in the areas of alcoholism, post-traumatic stress disorder, schizophrenia, and depression. His work links psychopharmacology, neuroimaging, molecular genetics, and computational neuroscience to study the neurobiology and treatment of these disorders. And he is best known for leading the discovery of rapid antidepressant effects of ketamine in depressed patients. He directs and co-directs the Yale Center for Clinical Investigation, NIAAA Center for the Translational Neuroscience of Alcoholism, and the Clinical Neuroscience Division of the National Center for PTSD. He is the co-founder and chief scientific advisor of Freedom Biosciences, a clinical stage biotechnology platform developing next-generation ketamine and psychedelic therapeutics that recently emerged from stealth this year, August 2022. On the show, we cover topics that include the neurobiology of a depressed brain, the relationship of thought and brain chemistry, anxiety and its connection to depression, pharmacology, getting into the various medications for treating depression, how antidepressants were discovered, and the efficacy of current antidepressants. And then we get into the neuroscience of psychedelics in the treatment of severe depression and PTSD. That then leads into a discussion into ketamine therapy, its benefits, the risks, and the treatment protocols, like the different delivery mechanisms, dosages, so on and so forth. It's very interesting. And since we do talk about substances like psychedelics and ketamine, which has psychedelic-like properties, here's a disclaimer. I'm not a doctor, nor do I play one on the interwebs. I do talk to them on the show, so I defer to those doctors and physicians. None of the content in this podcast constitutes medical advice or should be construed as recommendation to use any medications that are mentioned. There are psychological, physical, and sometimes legal risk with usage. So please consult your doctor before considering anything we discuss in this episode. Everyone's DNA is different, especially in response to any drug. So any positive anecdotals you hear here or anywhere does not mean your results will be positive in regards to medications. All right. All that said, Here's more information for you to consider. So I give you Dr. John Krystal. Dr. Krystal, welcome to the show. Up front, please correct me if and where I use incorrect terminology or I have assumptive definitions on some of the subject matter, or even based on context of how I'm using the terms. If you assume I know nothing, our audience will be better off for it. So with that, let me get started. And by the way, I heard your podcast with Tim Ferriss on ketamine. So
Yes.
I want to refer people to that on that subject matter. I do want to touch on that because of its impact on treatments for depression and what have you. But let's start with neurobiology. I think I floated to you initially physiology, but maybe more specifically neurobiology. What happens in a depressed brain? And if I'm phrasing that or framing it correctly.
Sure. So this is probably a good place to begin is the historical perspective, which is that what people thought was happening during depression, particularly in the 1970s and 1980s, was that when people got stressed and were feeling under a lot of pressure, feeling very discouraged or very hopeless, that they would get a depletion of certain chemicals in the brain. And the chemicals that they were focusing on were serotonin and norepinephrine. These are chemical signaling mechanisms that primitive parts of the brain that live in the brainstem use to modulate higher emotion centers and thought centers. It turns out that while there are some disturbances in serotonin and norepinephrine, they probably don't account for the full biology of depression. And in fact, my colleague, Dennis Charney, in collaboration with a number of other people, conducted studies over a number of years where these chemical systems were depleted in healthy people and they didn't get depressed. And this really helped to focus our interest in the kind of intrinsic biology of the higher emotion centers of the brain. And when I talk about higher emotion centers, what I mean by that are the cerebral cortex, which is involved in the executive regulation of motion, and the limbic system, parts of the brain that people may have heard of called the amygdala in particular, which is involved in the generation of emotional states. And that was really very profound in terms of our thinking because it shifted our attention, not completely so, but somewhat away from thinking about norepinephrine and serotonin towards thinking about the main signaling mechanisms that these higher brain centers use, which had almost entirely been ignored in depression research, which were the main excitatory system, which is glutamate, which accounts for something like 90% of the synaptic connections between nerve cells in these higher brain centers.
Excuse me, that was ignored?
That was ignored, yes, okay. Pretty much. And GABA, which is the main inhibitory system in these higher brain centers that would balance the excitatory effects of glutamate. So when we think of the function of these higher brain centers, we're often thinking about the balance between excitation and inhibition mediated by glutamate and GABA. And I know we'll come to this discussion later, but this kind of shift in our thinking really was very important in driving us to study ketamine effects in depressed patients in the first place. But now, 20 years on, 25 years on, in this line of research, my colleagues and I have characterized two main disturbances in the glutamate system in people who have depression. The first is that the glutamate synaptic connections become less efficient. In other words, per molecule of glutamate that is released, you get a smaller bang for your buck. In other words, the downstream activation produced by that single molecule of glutamate may be reduced. And then the second, which really was first identified a long time ago, probably more than a decade ago, by a trailblazing scientist named Bruce McEwen, which was that when animals are stressed for a long time, severe stress, they start eliminating or losing the synaptic connections in the brain. In other words, a given pathway that might have had 10 synaptic connections after chronic stress, maybe it has 8. synaptic connections. That's obviously a gross oversimplification because there's more like 1 billion synaptic connections in the brain. So we're talking about enormous numbers. But what happens in neural networks when you have a loss of synaptic connections is that information communication in the brain becomes less efficient. The information that's stored can become less precise. Another quality that gets compromised is something called plasticity, which is the ability of the brain to remodel itself in the context of experience, learning new things, adaptive regulation, things like that. So the main information highway of the brain, the glutamate system, turned out to be affected in depression as well. And similarly, the GABA system. So in psychiatry and in the context of the brain, which is so enormously complicated, there are many layers of neurobiological change, but suffice it to say that the brain circuits involved in the generation and regulation of mood become less efficient in their function and a little bit less functional. And some of the extrinsic tuning mechanisms that I was talking about before, like norepinephrine and serotonin, may also be a little bit less optimal. So it's a little bit complicated in terms of biology and involving many layers. But that, in a way, that shouldn't be surprising to us, because if it was just a small, simple thing, people's intrinsic, innate capacity for resilience would always overcome the temporary depression-related changes, when in fact, so many people end up struggling with depression for long periods of time. Even with psychotherapy or medication treatments, there are still people who will continue to suffer, which in the long run was one of the reasons that we continue to probe the biology to both better understand the disorder and to try to develop new treatments.
It sounds like there's not a primary pathology of depression in the sense that maybe you're saying the synaptic connections, if that's disrupted, is the primary pathology. But am I?
Well, my inclination is to say that depression, number one, that the biology of depression may vary in different people. Different aspects of the biology may be more or less important for some people. And it's not a single thing. It's not just low dopamine or low serotonin or high glutamate or one thing or another.
It's
but
an
rather,
ecosystem.
Exactly. It's really about how these networks get regulated, and that the fact that these networks are fine-tuning a really complicated process, which is how do we react to things? How do we adapt to stresses and challenges that we face? How is it that we're resilient? And those are really represented in very complicated ways in the brain. And what's remarkable is that we could find some common themes in the biology that we might be able to target with drugs like ketamine. And when I say it's remarkable, because the earlier generation of medication treatments for depression, the antidepressant medications, were almost entirely found by accident. In other words, the first monoamine oxidase inhibitors were first type of antidepressant, the monoamine oxidase inhibitors, were discovered because there was an anti-tuberculosis medicine that just happened to also be a monoamine oxidase inhibitor. And so they noticed that some TB patients started to find that their depression symptoms were going away. And then they tested the drug in depressed patients and showed that it could work. And similarly, observations about a different class of drug called the tricyclic antidepressants, that it was developed for one indication, but it turned out that depression was improving. And so they tested it as an antidepressant. So in terms of treatments for depression, the development of ketamine was, maybe the first antidepressant developed based on an effort to both understand the biology of depression, but then very rapidly a relatively more mature neurobiological hypothesis.
Is there and I want to get into ketamine for sure. I'm hugely curious, and you're the expert on it, but I'm going to do some softball pitches here.
Sure.
I'm assuming then there's not a chicken or the egg. In other words, is there a biochemical change? Then you're depressed. I'm assuming that can happen. Or do you depress and then the biochemical changes occur? I'm assuming both can happen. Okay. Because I've talked to pioneers, other psychiatrists, pioneers in, let's say, therapies, talk therapies or modalities like cognitive behavioral. And some of them are very opinionated about it's not really a biochemical issue. It can be, but at first I think, and I don't want to place them all in this camp, but it seems like some of them, their position is it starts with some belief thought, and then, there's these chemical changes. And so their mode of treatment then is those thoughts and beliefs, which I've seen it absolutely be effective. But there's that issue of medication and whether it's chemical or not chemical. Am I making sense?
Yes, absolutely. And I think, I try not to pigeonhole theory about the biology of depression. I assume any cognitive change in the brain has a neurobiological underpinning. I also think that you have this kind of feed forward and feedback process where
it's a vicious cycle.
Exactly. So you could treat something that started as a biological disturbance with psychotherapy, and you could treat something that started primarily as a psychological problem like a divorce or bereavement or something like that. And you could treat those symptoms with antidepressants because of the intrinsic oneness of what we're talking about, which is that the psychology and the biology aren't really cut off into two separate beings.
Nor should they be, right?
Yeah,
Nor should they be, right? Yeah.
Right. And what happens is that, though, that there are certain traits that predispose people to getting depressed. And so, for example, and they're inherited and they're genetic and they have a biological basis, but sometimes they're expressed as certain kinds of maladaptive behavioral traits. So, for example, there's a trait called neuroticism, which is related to the old idea of neurosis and has to do with a kind of perfectionistic, self-critical approach to the world, a very detail-oriented perfectionistic that makes it hard for people to forgive themselves or others around them when things aren't going the way that they want them to. Well, that's a psychological trait. It's not necessarily an underlying biology of depression, but it's a psychological trait that predisposes some people to developing depression.
Which then is that the downstream is biochemical, right?
Might very well be biochemical.
Or could be, yeah.
Yeah. So, and there are other people who have a variety of medical problems. They can be as diverse as obesity, heart disease, asthma. All of these kinds of diseases produce, even though they affect maybe the lungs more than other disorders, if it's asthma, or your heart, if it's cardiac disease, they also produce changes throughout the body that are called inflammation. And when you have inflammation in the body, you also have changes in the brain. Those inflammation changes in the brain also seem to predispose people to developing depression. And in fact, there are some people who have an inflammation-driven form of depression, and certain anti-inflammatory medications used to treat immunologic disorders like psoriasis sometimes can have antidepressant effects in people who have an immune-driven form of depression. The inflammation in the brain is contributing to the biology of their depression, just as the inflammation in their body might be contributing to their heart disease or their diabetes or other things. And so one of the kind of really important ideas in this era for people to understand is that their depression and their overall health are very closely related. So if they have an episode of depression and they don't treat it, that will not only affect their attitude and approach to the world, but it will set them up for other medical problems down the line. It may make an existing vulnerability to other medical problems more likely to be expressed as illness or a more severe course of illness. So one of the things that we try to do is to think of mental health as part of overall health. And, we're very much part of the group that says, if you have good medical care, but not good treatment for your mental health, that's not optimal medical care because of the really close tie between what's happening in your mind and your emotional life and what's happening in your body.
Yeah, we're back to the ecosystem, right? It's all
Right.
everything's connected, and then there's studies. Don't know how reliable, but on the benefits of exercise and activity, physical activity for depression. So it's another example of possibility there. I've also heard a sleepy brain is a depressed brain. I don't know, because I've also read where restrictions on sleep can improve mood. Is there any truth to any of that?
Yeah. So first, exercise. Absolutely. Exercise promotes both psychological resilience. In other words, gives you feelings of mastery and competence and effectiveness, but it also reduces inflammation in the body. You can show that the more exercise, the more regular exercise, and often group exercise, can be really powerfully protective against depression or even have antidepressant effects. One of the things that we learned about sleep and depression is, first, when you have depression, your quality of sleep goes down. Oftentimes you have difficulty falling asleep. You wake up in the middle of the night, you can't sleep. You get up early in the morning, you can't fall back asleep. All of these sleep disturbances contribute to compromised emotional resilience during the day, and people are less functional. So that feeds forward with the depression in leading to functional impairment. But if you totally sleep deprive people, so they get no sleep at all, then some people will have a temporary improvement in their mood that lasts until they fall asleep, and then the depression will come back. And there's been a great deal of interest in how circadian rhythms are linked to mood and how this total sleep deprivation produces its rapid antidepressant effect. Unfortunately, the temporary nature of the mood improvement has prevented it from becoming a form of treatment.
Let's talk about the efficacy of current antidepressant medications, specifically, and please give me other classifications: SSRIs, lithium, aminoketones, unless I'm leaving something out. Because Prozac has been written about as being on par with placebo or less effective than, say, talk therapy or CBT. But what say you, and where are we now with the research into these antidepressants?
I think the SSRI medications, SNRI medications, first, they're helpful for a lot of people. And I want to reassure people who are taking these medications or being prescribed these medications that anything that we say in our discussion today about the shortcomings of these medications shouldn't discourage people from staying on the medications if they work for them, or going on the medication if a doctor tells them they're going to be.
There's a population distribution, so it works differently on different people. Yes.
Right. Yeah. So the concerns about these medications really are about for the people that they don't work for. And I think that the early clinical trials of the medications led us to have an overly optimistic view of how effective they were, partly because in the early days, we didn't see all the results. In other words, what the papers that were published were predominantly the positive or successful clinical trials. And in the early days, we didn't see all the trials that were not successful. So it's helpful sometimes to look at data from some subsequent studies. And a very influential study was a study called the STAR-D trial of the National Institute of Mental Health. This is a large multi-center trial that took people often who were not naive in terms of their treatment. They had been often treated before. So they were not perhaps completely, some people may have had some degree of non-response already at the time they entered in the study. But what that study showed was that if you take a big group of people with depression and you treat them with an antidepressant medications, about a third of patients will respond to the initial medication that they're treated with. Not respond, but have a complete remission. In other words, all their depression symptoms will go away. And that will take about 2 months. So in some ways, that's good news. A third of patients will respond, have a complete remission of their depression, basically, and that will happen in 2 months. But for a lot of people, 2 months is an awfully long time to wait. And then smaller percentage of patients responded to subsequent trials. And they tried various things. They tried switching antidepressants, and they tried adding a variety of drugs, including lithium, to the antidepressant. And at the end of the year, after up to 4 trials, there was still about a third of patients. By that time, about 70% of the people in the study had achieved remission, but about 30% had not. So that study kind of frames something a little bit closer to the real world of psychiatry, which is that oftentimes somebody who doesn't respond to initial treatment will have a really good response to some other different medication combination. But if you stick to the standard treatments, there's still a group that it's not likely to respond over a year. So the second study that has influenced my thought a lot also has to do with the heterogeneity or spectrum of depression, and also overall supports the effectiveness of the SSRI medications, which is a reanalysis led by one of my colleagues, Relitza Gorgueva, who we analyzed duloxetine, which is something called an SNRI, serotonin and norepinephrine reuptake inhibitor.
What was that name again? Sorry.
Duloxetine or SNRI?
Yes.
Yeah, duloxetine. Yeah.
Thank you.
A Lilly drug, a very successful antidepressant. And we reanalyzed the data using a different kind of analysis than is traditionally used to analyze clinical trial results. But the point of this analysis to try to help us to see what were the different paths that patients tended to enter once they entered treatment. And it turned out that if you were in this large sample of over 2,500 patients, if you were treated with duloxetine or fluoxetine, in other words, Prozac or Cymbalta, that 75% of patients were better off on their antidepressant than they would have been had they been treated with placebo.
Okay.
And I think that's really as unbiased a way as I know of, because the data generated the clinical profile and identified a subgroup of people who really looked like they were benefiting. And that 75% is a large percentage of the patients who entered those trials. What was interesting and kind of surprising to us, though, was that about 25% of patients who received the duloxetine or fluoxetine, they improved a little bit over the course of the study, but it looked like they were worse off on the medication than they would have been had they gotten placebo. And what that says is that there's a subgroup of patients who get these medications who might be better treated with other classes of medications. And it's even possible, although I don't think you can really conclude it in any kind of definitive way from this study, there's some people where the SSRIs or SNRIs might just not be good medications for them to be taking for their depression. And that's a really important idea, because it means that it's important for doctors and patients not to give up if the initial medication treatment doesn't work. And oftentimes what doctors and patients do together is they say, okay, I started out at a 10, the worst I could ever imagine feeling. And then after a month or two of treatment, I'm down to a 7. Now, 7 is pretty bad, right? A 7 of depression, in other words, say 70% of the worst kind of depression that you've ever had in your life is still pretty symptomatic, but 30% improvement is pretty good. So how do you decide whether you've really optimized where you are? I think if you start from the perspective that the goal is to get people to an adequate clinical response, which is more like a 50% reduction, or even to remission, which is more like an 80 to 90% reduction of the depression, then you don't give up. You don't accept not sleeping, being anhedonic, not having any appetite, having no energy or focus, feeling disconnected from the people around you, being preoccupied with negative thoughts. You don't accept that as a necessary status quo. And I think the STAR-D data are really strong data that says that it might not be the same medication that's added or the psychotherapy that's added might not be the same for all people who are struggling with depression. But it's really important for the treatment team not to give up just because the first treatment, no matter what it was, psychotherapy, medication, different kind of medication, didn't produce an optimal response. And what's kind of shocking to me over and over again is how many people I meet or where that happened, where they just stayed with whatever they started with and it wasn't optimal. And also that how little we use the treatments that are most effective for the most severely and persistently ill, depressed patients. And in this era, that would be a neurostimulation treatment like electroconvulsive therapy or ketamine and esketamine.
Which we're headlong heading into here. I forgot to bring it up when we were talking about physiology, neurobiology of a depressed brain.
Sure.
And I wanted to ask about anxiety. Are they related in the sense of what is happening to a brain when we talked about the ecosystem and synaptic connections?
I think they are.
Can you knock out one, the other goes with it in that sense?
Most commonly, if you have a very severe anxiety problem, you will also have symptoms of depression. So, for example, people who have panic disorder will very commonly also have symptoms of depression. And there's an anxiety disorder. Panic disorder is when anxiety comes on in waves or attacks. And people may be feeling okay in between the anxiety attacks, but have a lot of distress when they're in a situation where that tends to bring on their anxiety attacks as they're anticipating something bad happening. But there's another kind of anxiety called generalized anxiety disorder, where people get up in the morning feeling anxious and they feel anxious all day and go to sleep anxious. And they don't have necessarily the waves of anxiety like panic attacks. What's interesting is that from a genetic point of view, it appears that some forms of major depression and generalized anxiety are the same disorder, just of people who have different kinds of environmental exposures. So there's probably a fundamental connection between depression and certain kinds of anxiety, like generalized anxiety disorder, but there are very high comorbidity rates. In post-traumatic stress disorder, which is a disorder where you can see a lot of anxiety as well, particularly when people are exposed to reminders of their traumatic situation. What you often see is that the more severe the PTSD, the more the PTSD is associated with symptoms of depression. So if you work with people who have severe PTSD, almost all of those patients have to some degree symptoms of depression and may make the diagnostic criteria for major depressive disorder on top of their PTSD as well. So they are really very closely related. And not surprisingly, most of the antidepressant medications not only treat the depression symptoms, but also are effective when they work for the anxiety symptoms as well. There is, though, an important story for the psychiatry community about the comorbidity of anxiety and depression, which is that historically there are kind of, you might say, two main flavors of depression. One has been called by the psychiatrists melancholia. And the word melancholia is really a wonderful word. It goes back to the Greek Hippocrates because melancholia means black bile in Greek, and was one of the four humors that people thought influenced kind of fundamental aspect of what they thought was going on in the human body. But melancholia is a kind of depression that is like a folding inwards, where people are caught up in their own thoughts, a blunted emotional reactivity, no experience of pleasure, social withdrawal, no energy. Some people use the word involutional to describe this kind of shutting down. But there's another kind of depression that's associated with a lot of anxiety and panic attacks. That's really not so much people feeling heavily burdened by depression all the time, but people who react very strongly to negative situations in ways that they can't really manage very adaptively, and that where they get very agitated and they get very anxious. And for some antidepressant medications, that distinction is important because that kind of anxious, highly anxious state in depression is sometimes a sign that people will not necessarily respond to their initial treatment and may need other forms of treatment combined with an antidepressant. But basically, even though we have some very different kinds of presentation of depression, most of those kinds of presentations will respond to a medication in combination to a psychotherapy.
So I want to get into, I guess we're approaching a new era in psychiatry, it seems, with the potential use of psychedelics in treatment. And I know there's a lot of research. I know there's a variety of psychedelics that are various stages of being studied now and what have you. But I want to, because of your expertise in ketamine, I want to park there and discuss it. And just keep it at a high level, because I would point people to the discussion you had with Tim Ferriss, because it's a 2-hour deep dive into the use of ketamine and what have you. And it was fantastic, by the way. So I'm seeing locally and elsewhere treatment centers that their main protocols are the use of ketamine. So let's talk about how ketamine works in the sense of its antidepressive and, I'm assuming, anti-anxiety effects. How does it work and why does it work?
Right. I think for ketamine, it's sometimes helpful to draw a distinction between the low dose of ketamine that's sometimes used as an anti-anxiety medication from full antidepressant dose of ketamine that we're usually administering intravenously. It could be administered intramuscularly. In theory, it could be administered orally, but it's more challenging to get enough ketamine into the body orally to get the full therapeutic dose.
And let's talk about what's enough and dosing and just ranges at least. Yeah.
Yeah. So
the antidepressive effect, is it?
The standard antidepressant dose of ketamine for an intravenous administration, administered over 40 minutes, which is sort of the standard infusion length, is 0.5 milligram per kilogram or 35 milligrams. Now, the body chews up ketamine. So if you give it orally, you have to give quite a bit more to get the same blood levels. So one company is giving 100 milligrams, but it's not clear that 100 milligrams gets you, even 100 milligrams given orally gets you into the same dose range, that blood level that we get. And there's kind of a little bit of a narrow window in the dosing. So if you go down during the 40-minute intravenous infusion, if you go down to 0.25 milligrams, 0.2 milligrams, it's not effective for treatment-resistant depression symptoms. At 0.5 milligrams per kilogram, you do get dissociative symptoms. You do get other kinds of experiences associated with it, but you also see the antidepressant effects.
By the way, sorry, forgive me, is the dissociative effect a marker for an effective dose?
It tends to be. In other words, if you're in the sub-dissociation, if you don't get any dissociative symptoms during ketamine, many people will not have effects. However, there are groups of people who have built-in tolerance to the effects of ketamine, who just don't experience much in the way of dissociation with traditional antidepressant doses of ketamine. And those are people who have a history of alcoholism, or a strong family history of alcoholism.
But then is it not effective for depression?
No, but it tends to work for them.
Oh, that's interesting.
Yeah. So it's not a one-to-one relationship of the intensity of the dissociative symptoms and the magnitude of the clinical benefits. But I think for many people, it tells you you're in the right range. And this gets to a study that we did about the biology of the antidepressant effects of ketamine, where this is a study conducted by Irina Esterlis and Sophie Holmes at Yale in collaboration with a number of people, including the Yale PET Center. And what they did was to use a PET radio tracer to characterize people with depression as to whether or not they had synaptic deficits, actual reductions in the number of synapses in the limbic system and cortex of their brains. And it's a pilot study, but the results are very, very interesting. In the group that had normal synaptic density, now they may have had other things related to synaptic efficacy or other aspects of their biology, but they didn't have reductions in synaptic density. In those people, there was no increase in synaptic density because they had normal synaptic density to start out with. Dissociative symptoms were unrelated to their clinical improvement. In the group that had synaptic deficits, you saw after a single dose of ketamine increases in the number of synapses in their brain, or at least a marker of that. And in those people, dissociative symptoms were associated with their clinical improvement. So again, in different groups of patients, dissociative symptoms are relatively more or less related to whether or not they're improving clinically. And it's probably a marker, not of efficacy per se, but that you got enough ketamine to trigger the downstream reactions to regrow the synaptic connections. And if that's what you need to get better, then perhaps in that group, it may be more meaningful as a marker.
So I reached out to some people who had the ketamine treatment, and they were kind enough to give me their experiences. And it seems different than, let's say, something like psilocybin, and we're for the audience, magic mushrooms, right, that kind of thing, where right, there's not so much a vision or visions, but there is this disassociation where maybe parts of your body are numb. And is there an easy way to describe the experience outside of just disassociating?
So I do think it's different.
Everybody's different. That's hard to answer.
No, but in the subjective effects of ketamine versus the psychedelics. So when you talk to people who've just had psychedelic treatments, it's much more common for them to talk about how meaningful it was, what insights they had, how the actual experience of what they went through during the psychedelic experience was related to something that they're continuing to think about after the episode. That can happen with ketamine, but it's much less common. On ketamine, people are much more likely to have experiences where they experience that their body is altered, their sense of time slowed down. They might experience the walls as breathing in or out. They may, experience other kinds of sensory distortions or changes in what their usual thought patterns. And it's less clear that these kinds of insights or experiences are directly related to the treatment. Although that doesn't mean that there aren't productive ways to potentially combine ketamine and psychotherapy treatments. I think that's really an important area of work right now.
And harking back to talking about pathology pathways, is the effectiveness of ketamine for depression, which I'm assuming you're advocating for, that it is very effective.
Yeah.
Is it because of the glutamate and the synaptic connections that it modulates or improves?
So the animal studies suggest that the antidepressant response starts without the regrowth of the new synaptic connections, but that maintaining the antidepressant response to ketamine depends on maintaining these newly formed synaptic connections. And the clinical data so far seem to be consistent with that. But for the antidepressant response to last more than a few hours, those synaptic connections that are made need to be sustained. And so in animal studies, when they prevented those newly created synaptic connections from really lasting, the antidepressant response was really very brief. But when they allowed them to go the full length, then they got, the much longer response. And when we've done an experiment in humans that may actually even turn into a new treatment, where we gave a drug that may have protected the newly created synapses from being broken down. And that looked like it extended the duration of the antidepressant effects of ketamine.
So let me see if I understood you correctly, and even though you didn't say it this way, let me just, this is kind of how it landed on me. Are there two benefits or two positive benefits as to depression when it comes to ketamine? In the first, when you're receiving it, within the first couple of hours, there is an antidepressive effect, but it also fosters the growth of new synaptic connections longer term afterwards. So there's
Right.
Well, that's interesting. Wow.
Yeah. And that's really why a drug that is really short lasting, like ketamine, can, even with a single dose, produce antidepressant effects that can last, for weeks in some people. There is some convergence with what's being found with the psychedelic drugs, at least in the animal models so far, that some regrowth of the synaptic connections as well.
Now, is it a curative, or is it something someone needs to constantly repeat? In other words, those synaptic connections, do they come and go or degrade over time? And forgive my terminology.
Yeah. So the synaptic connections do come and go all the time. That's their nature. You might think that a given synaptic connections might represent a memory or something like that, but it turns out that they really are quite dynamically regulated. On the other hand, what we think is happening in depression is that the balance between new synaptic connections being made and synapses being lost favors synaptic loss. And with antidepressant treatment, that favors synaptic stability. So, we do think that this process is important and relevant to both the negative effects of stress and the positive effects of treatments.
Is it possible for somebody to do a temporary short-term series of ketamine treatments and that be curative, or that be it? I know it depends on the person. Or is this something that every year somebody with treatment-resistant depression would have to do, or do we know?
Yeah.
Or do you know?
So there are some people who seem to do very well with very few doses, but there are also people who follow what is emerging as a more typical path, which is they start twice a week, then they go to once a week, then they go to every other week, and they gradually space out over time the frequency of the dosing. And at about a third of the patients who are on longer-term ketamine or esketamine treatment in our clinic, at least I'm told, are getting their treatments administered every month, sometimes less frequently than that. For reasons that we don't yet understand, we don't know if it's different patients or differences in how the drugs affects the brain. The psychedelic studies, which have been mostly not conducted in treatment-resistant depression patients, but rather in more straightforward depression populations, they tend to get longer-lasting antidepressant effects. It would be interesting to know what happens when these drugs are administered to patients with treatment-resistant forms of depression, because these patients have greater risk of relapse. After a person with really treatment-resistant depression, it may take them a year to get a treatment response, but the chances of relapsing over the subsequent year with standard antidepressant treatment can be 50 to 75%. And that can be really discouraging. One of the things that's really kind of exciting about drugs like ketamine is they're not only doing a little bit better job in getting some of these folks better more rapidly and more effectively than standard antidepressants, but they've been protective against relapse.
I'm thinking as you're talking in dealing with improving synaptic connections is long-term, is that I would assume that's good for the brain, or are we too early here to determine long-term?
I think of the maintenance of these newly created synapses as the outcome measure, but the processes through which ketamine produces its antidepressant effects seem to be related to mobilizing the brain's own mechanisms for resilience to stress.
Well, that sounds great.
It sounds pretty good. So, for example, one of the things that happens when you administer ketamine, and I'm going to use a very simple analogy, and I hope you pardon it. I'm happy to give you the excruciating.
Know who you're talking to. It's all about simple.
There are excruciating neurobiological details, but there's a really critical resilience mechanism in the brain called neurotrophic factors or nerve growth factors. And there's one of these nerve growth factors that's affected by ketamine is called brain-derived neurotrophic, in other words, nerve growth factor, BDNF. And ketamine may raise those BDNF levels in the brain in two ways. One way is that by creating a pulse of glutamate release, it triggers a signal in the brain that the pathways are being meaningfully activated. And by stimulating a particular type of glutamate receptor called the AMPA-glutamate receptor, you might say it steps on the gas and helps to raise that BDNF level. But glutamate is, although it's excitatory, stimulating activity in the brain, it can have negative effects as well if there's too much glutamate in the wrong places. So one of the things that happens, and it's a little bit, I don't want to get into too much detail, but when too much glutamate is in the wrong place, it actually acts like a brake on the resilience mechanisms of the brain. And the brain triggers mechanisms to protect itself from toxic glutamate. And that drops BDNF levels and causes the synaptic connections, contributes to the synaptic connections being eliminated. So ketamine blocks that negative effect of glutamate and stimulates a positive effect of glutamate at the same time. So it steps on the gas, takes its foot off the brake, and you get this relatively rapid and pronounced increase in this brain resilience mechanism, BDNF. And the positive effects that ketamine has on depression are probably downstream of that nerve growth factor, that resilience mechanism being engaged.
I'm assuming, let me throw this out, if someone sees their psychiatrist, their doctor, right, and this is, they have treatment-resistant anxiety or depression, and let's say they're going to try the ketamine route, that the most, I'm going to use the term effective methods for administration would be intravenous, followed by maybe nasal, and then maybe, or maybe not, oral. And you could also throw in intramuscular, I guess.
Yeah. We know so much more.
Or does it matter, or is it just a matter of changing the dosages based on the delivery mechanism?
Well, I was just going to say that we know so much more about the intravenous and the intranasal treatments than we do about any other treatments. That it's hard for me to comment on the other ones.
Sure.
Generally speaking, the intranasal treatment was designed from the outset to capture the effectiveness of the intravenous treatment mechanisms. And the people who, there was a kind of group started at Yale. Some of the folks moved to the National Institute of Mental Health. The group from the National Institute of Mental Health, some of the key people moved from there to Janssen Pharmaceuticals, and they were the people that developed. And so the link between the intravenous generic ketamine and the intranasal S-ketamine developed by Janssen is a pretty direct link. And so I don't think there's that much difference in efficacy of the intravenous and the intranasal ketamine.
Interesting.
And I mean, there are some differences. Some people hate needles. Some people hate.
Oh, that's a big difference.
Putting things in their nose. Also, there's a little bit of a difference in how the dose is started. When you get the intravenous dose, you tend to get the full dose right off the bat. Whereas if you get the intranasal dose, you tend to start at a little bit of a lower dose and build up to the full dose. So, they're used in a little bit different ways, but basically they're the same treatment. Whereas the oral ketamine, it's not standardized like the other two are at this point.
Man, it's so great to have an expert like you on for these questions. I forgot to ask you about the K-hole experience. You don't need to reach that level of administration or that level of experience to have the antidepressant effects, or do you? And or if you, and we'll define the K-hole experience, but if you reach that level, does that mean, is there too much? In other words, can you tip over and not have the effect because you've had too much?
The answer is yes, but probably not at the level of the K-hole. So if you go towards the anesthetic doses where people are really falling asleep, at those doses, you're probably diminishing the antidepressant effect. And the full anesthetic dose does not appear to be antidepressant. So when people get an anesthesia using ketamine, They don't
That's
necessarily.
That's what you're talking about. They don't necessarily get the effect.
They
Putting
don't
someone
get
to
it.
sleep with it. So
Right.
just so that the audience knows, that was its primary, I think, right? Use
That's
of ketamine, right?
Absolutely.
But that's not having that much to whatever that dose is to put you to sleep. You're saying that may not produce the antidepressant effect. Okay.
It doesn't appear to.
It doesn't mean if you get sleepy on it, you're not going to have the effect. It's
That's
a
right.
specific, you're going to go out. Sorry.
Yeah.
It's just like any other anesthesia.
Right.
Okay.
And the K-hole occurs, some people will get the K-hole experience during a typical therapeutic dose of ketamine. And the K-hole is kind of a constriction of their attention and perception interaction with the world.
Visual field, maybe.
Yeah, they get like an experience of tunnel vision. And some people find the K-hole experience very disturbing and frightening. Other people find it kind of inspiring, like being reborn or something like that. And my guess is that that's a very individual thing, but that the K-hole itself tends to occur.
It's not a necessary or sufficient marker. Okay.
It's not necessary or sufficient, but if you've got the K-hole, you certainly got enough ketamine. You don't need it anymore.
That's a great way to put it.
Yeah.
Dr. Krystal, thank you so much. This has been very, very interesting. Is there anything related to this topic that I would be remiss in asking that we should address? Yeah,
I there is one thing that I think is worth talking about, and that's side effects and risks, right? Because I've highlighted aspects of the effect of this medication and the exciting research that's coming out about the neurobiology, but we haven't talked about side effects. So the typical side effects are it can make some people feel nauseous. They can get a headache. Sometimes some people will not only be nauseous, but may vomit. That can happen. But if you have a little bit, and some people will have a small increase in their blood pressure. If you have nausea and vomiting as a side effect, there's a medication that can be given to prevent that. If you have an increase in blood pressure during the ketamine infusion, a medication can be given to prevent that. But the thing that we can't prevent with the medication yet is the abuse liability. So one of the things that we're mindful of is that as ketamine has emerged as a treatment, that the rate of recreational use of ketamine has increased in the United States. And one of the reasons that ketamine is given in the clinic is so that the medical side effects can be managed and the dissociative symptoms can be managed, but also because when you give ketamine in the clinic, it helps to manage the risk of developing ketamine addiction or misusing ketamine. And that's certainly something that we are mindful of as ketamine.
If you have to make an appointment to go to a clinic, you're less likely, to, especially because you're monitored, right, to become dependent. Sorry.
Right. Yeah, absolutely. So, I think we're in an era where people are interested in moving ketamine out of the clinic and into the home. And these are some of the issues that we'll have to pay attention to as those programs develop.
Well, you've been at this research for a long time and a pioneer, I believe, as well. So you must be excited to see, or are you, or maybe you have mixed feelings about a broader adoption and to see this in treatment?
Well, I think that a critical issue, that there are still a lot of people who need access to treatments like ketamine who aren't able to get it. And I'm very mindful of how many times I get emails from people who say, I can't figure out how to get access to it. I don't know who to contact. I don't know where I can get access to this kind of treatment.
It's not covered by, or is it by insurance? I don't.
The S-ketamine tends to be covered a little more than the racemic ketamine, but the standard generic ketamine is starting to get covered by insurance as well. So, I think that's access is still an issue, and equitable access to it in terms of people who don't have the financial means for whatever reason. So that's something that we're all still mindful of. But I have to tell you that some of the most moving experiences that I've had in my whole life have been from people who've written to me or let me know about how helpful ketamine was for them in helping them to get on their feet. And we all strive in research to to do something that has a positive effect on people's lives. And I can't tell you how inspiring it is to hear from people that something that I was involved with had some, positive effect.
Look, I'm not a theist, but you're doing God's work. And that's the whole thrust of the podcast. There's people, when they find out I was talking to you, all of a sudden, depression, the turmoil, all this came out. People were saying, ask this or what about that? And, I know one specific person, just incredible anxiety and what have you. I mean, given the times and everything that's going on, right? One of the challenges of modernity, I guess, is the impact on our psyches. But so God bless you, Dr. Krystal. And listen, thank you for coming on. You're going to help a lot of people in my audience as well. Where can people find you and your work and dig deeper?
So I think a good place for people to start if they want to learn about ketamine and learn more about ketamine, as you point out, and if they're very patient, they can listen to the podcast with Tim Ferriss, where we talked a lot about these issues. We had more time to.
I was wrong. It may have been over. Maybe 3 hours. I'm not sure. I think it might have been, even longer.
Yeah.
Go ahead. Yeah.
Yeah. We have programs for ketamine treatment, ECT treatment, depression treatment at Yale. And I'm happy to help to direct people who are in the area and would like to be connected to treatment and help them if there's a way that I can to get connected elsewhere.
Dr. Krystal, thank you for coming on. Thank you for taking time out of your busy schedule. I really appreciate it. And I think you're going to do a lot of good.
Well, thanks so much. It's really been a pleasure to talk and I appreciate the opportunity to go over this stuff. So thanks for inviting me.
Well, that's a wrap. Thank you for listening. If you enjoyed it, do share it with your friends and on your social platforms. Big thanks to Sam Williams, my audio guy, and the beautiful bumper music you're hearing is Michael Petrovich's Bella Luna. For all my show notes or resource links, visit LarryWeeks.com, and we will talk again soon.